Okay, great. I think we're up. Hello, everyone. Hope you're having a good day, and thanks for joining us. I am Kelly Caseman. I'm the Executive Director of Think Kids, and today we have 4 panelists joining us to talk about neonatal abstinence syndrome in West Virginia. If you're watching us live on YouTube, please feel free to write any questions or comments in the section below the video, and we'll answer them as the conversation continues. I'm going to quickly introduce our panelists and ask them to share a little bit about themselves and the work they do as we go along with the conversation. So with us today, we have panelists in alphabetical order. Cindy Chamberlin, she is the president of the West Virginia chapter of the To the Moon and Back and owner of Powell Physical Therapy. Hey, Cindy.
Hello.
Rhonda Edmunds, she's the director of nursing at Lily's Place.
Hello.
Molly McMillion, she is a special projects consultant with the West Virginia Perinatal Partnership.
Hello.
And then we have Dr. Jennifer Mills Price. She's assistant professor with Marshall Family Medicine and project director of Healthy Connections. So thank you all so much for joining us. So let's begin with the basics, which seems like you just, would have an easy answer, but doesn't. And that is, what is neonatal abstinence syndrome?
Well, I can start off with that. And West Virginia adopted a definition for that. And NAS is given as a diagnosis to a baby when they have had an intrauterine exposure to a neuroactive substance, and then they experience signs and symptoms of withdrawal. And that diagnosis is given whether or not that baby has to be treated with medication for those symptoms of withdrawal or not.
Great. Thanks, Rhonda. Anyone want to add to that? Because I know we had a rather robust conversation about it when we were prepping for this video.
Well, I know Molly had kind of clarified, and I also know that last week at the RX and Illicit Drug Summit, there was a lot of talk among neonatologists there about trying to get a consistent definition so that we're all kind of defining or saying the same things, because sometimes people are referring to it as now, which is the opioid withdrawal. And then there's also some drugs that don't cause any withdrawal symptoms, for example, marijuana, right at delivery. And so those are what we are considering substance exposed children and not necessarily getting diagnosed with NAS.
Thanks, Cindy. What drugs and medicine can cause neonatal abstinence syndrome?
Typically, it's an opiate. And I know here at Lily's Place, the babies that have had that prenatal exposure and had symptoms of withdrawal, they are treated with an opiate because of that opiate exposure.
And I think that the polysubstance use is on the rise, but also so are stimulants. So methamphetamines are also one that we see commonly.
And to put some context around it, because all of us have been doing the kind of work we do for a while, neonatal abstinence syndrome isn't exactly new, but the opioid epidemic is what really exacerbated its rates in our state, would you say?
Absolutely. Absolutely.
And I'll add that prior to the opioid epidemic, neonatal abstinence syndrome was not necessarily kind of exclusively referring to opioids, and I think it's taken that on. So there are a lot of medications as well as illicit drugs that a mother can ingest during pregnancy if they cross over the placenta, and the baby can't experience withdrawal from those. So an example, or certain antidepressants can create neonatal abstinence syndrome in infants. But in my experience and my line of work, I think I most commonly see that referred to in the context of opioids, and then illicit drugs. I will say, though, that we, sometimes also we'll see infants that are on prescription medications that can complicate opioid withdrawal. So for example, gabapentin, if it's taken in conjunction with opioids, even those that are completely legitimately prescribed, that can complicate the withdrawal syndrome that the baby experiences.
Yeah. And just to kind of go along with that, with gabapentin, typically the babies are getting so overstimulated just by kind of being in their setting that they tend to fall asleep. And so the red flag for me is when I hear that somebody has brought a baby home that's been substance exposed and they're sleeping 20 out of 24 hours a day, and they actually have to wake them up to feed them. And typically what we're seeing, at least in birth to 3, is we're getting these children once they have a failure to thrive diagnosis, and then we kind of have to go like back up a little bit, and we realize that they were exposed to gabapentin while their mom was pregnant. But
Thanks.
I was gonna say, go ahead.
I was just gonna say, can you see my screen?
Yes, very
Yeah,
good.
I just I'm sharing that. That is from these are some stats from the Project Watch, the West Virginia Birth Score program, and pretty up to date. And just to kind of, when we talk about drugs that we're looking at in the state and the most commonly used that we're seeing, of course, you see here cannabis, you know, number one, and we're not even listing tobacco on here because it would be way up above even these, right? But you know, the cannabinoids, opioids, you know, and then it's really the stimulants have taken over the next spot. You know, we're seeing that more and more, which is tough because everything that comes along new, it's like when I started, you know, learning in this area, so much was known about cocaine and its effect on pregnancy, you know, and babies and that kind of thing. And it's been slow to evolve, but now then we got really good about opioids. The stimulants, you know, particularly methanol, meth, and such, we're still learning, like all of it. But like Cindy said, the fact that in so many cases, there's a mixture here. When we say polysubstance abuse, it's more than one substance at a time. So that makes it even more difficult. Even if, though, and I may be skipping ahead here, a baby, you know, we have a group of babies and they're all exposed to the exact same substances and all. Whether that child shows signs of withdrawal or not is going to vary, you know, just because all of our individual makeup. So it, you know, a lot of work has been done to screen, you know, but it's hard going, even when you know what you're dealing with.
Mm-hmm. Well, and I kind of feel like 100 years from now, when everybody's got this all figured out, I think it's going to be when in utero was the exposure, not necessarily like how long, but who knows? Because I mean, I will say, like, from working in the NICU, nicotine withdrawals don't last as long, but they're just as difficult to watch the baby go through. The baby's extremely irritable and is very, very fussy, and it can be really hard. Just when you think about smoking, and I believe West Virginia is still number one. I was gonna say, I thought they were still number one for smoking and pregnancy. And that's something that could so easily be eliminated to help these babies transition, you know, into the world with one less substance in them.
Right, you're right. It complicates, you know, so much of the picture that we see. I just wanted to show this, and it's a lot of lines and numbers and everything, but just to give you an idea, Project Watch looks at the intrauterine substance exposure, and that's this blue line up here, okay? And so the state, although you can see like a spike here, we've run around 14%, you know, from the get-go with, you know, some ups and downs, whereas down here with NAS, same spike in here, you know, and that was in January of 2021, and we can all kind of go, oh yeah. but your actual rate of babies being diagnosed with NAS is an average of 5, and all, with some high and some lower. Yeah, but that, and of course it varies in different regions around the state. Yeah. So
and I think we had talked a little bit about this like at our pre-call. Do I think that we're capturing all kiddos that have been exposed? Absolutely not. We do know that some moms will cross state lines to deliver. Some moms try to get discharged like at hour 25 so that symptoms for withdrawal aren't necessarily showing up. And then some kiddos might not start showing withdrawal symptoms until almost a week after birth. So it's a challenging situation just to make sure that we're doing everything we can for these families.
Good point. And I think that West Virginia has, correct me if I'm wrong, one of the most robust surveillance systems for neonatal abstinence syndrome in the country.
Yes, some states are just starting, like Pennsylvania is just starting with opioids. And I think that Kentucky has now expanded theirs to add the stimulants. And then they're also looking at the differences between polysubstance use, methadone versus Subutex. So they're kind of looking at all of those differences to see if it's the polysubstance use or if it might be a medication that might be causing some issues with those children.
So this is an important next question, and it's one of those that's hard to answer, but important to discuss. And that is, what are the risks for children born with neonatal abstinence syndrome?
Well, I like to call them the Energizer bunnies that you can't necessarily take the batteries out of. So they tend to be very active. Early on, it might be lots of arching, lots of extending, trying to give their airway room, trying to give their gut room, if they've got some tummy issues or issues with reflux. And then for those kiddos that don't necessarily get a lot of tummy time in their first 6 months, like once those kids start learning to move, they look like the bull in the china shop because they're always chasing their balance because they don't have good core strength or midline strength. So I think that that's why sometimes people assume or tend to say, oh, they have ADHD-like symptoms or they have autism-like symptoms because they have sensory processing dysfunction. And so all of those things can look very similar, but kind of the mode of how you get to them happens a little bit differently with those 3 diagnoses.
And of course, really early on, they can have poor weight gain and they develop the failure to thrive. And seizures are even a risk. So we're hoping to prevent that as well.
And I know diaper rashes, like very early on, like usually it's cleared up by the time I get them in birth to 3, but I know just as some of that medication's passing through the baby's guts, they can really tear up their bottoms.
Yeah, I'm glad you brought that up, Rhonda, as far as, a seizure is a danger when you're withdrawing from substances. Thankfully the incidence is, I believe, pretty low for that. But, physiologically, NAS can affect every system for an infant. And some you can see more than others. It can affect how they regulate their temperature. In fact, a lot of times, especially years ago, it used to be mistaken for an active infection or sepsis in the newborn. And also, it can be hard to comb that out of there. The main way that it's distinguished is with so much screening. And that's when I say screening, and like Cindy said, we know that some are going to fall through the cracks. We know that, parents are aware that this is, that there's screening going on and all those kind of things. But the more areas, the more prenatal care moms get, And not just the screening, but also offering the help is good too, because we want to know about it ahead of time. So much more helpful for the baby. And then, like, I'm sure we're going to talk about in a minute, as far as the follow-up too.
And I think one risk that we often don't think about is that maternal infant bonding, because these babies can be so inconsolable, and we want mom to be there and to equipped prenatally to know what to expect after this baby's born, so that she can be the first line of treatment for this baby and really be involved and feel empowered to take care of her baby.
And I think so often right along with that, Rhonda, is that we don't always like think that also by allowing that baby and mom to stay together, and every time that mom holds the baby, she's calming the baby just because it's mom, but her body is also releasing oxytocin, which can also be a calming, relaxing kind of hormone for the mom. So it's a win-win situation. And it kind of can help decrease stress levels with the mom as well.
Thank you for bringing that up, Cindy. I think it's really important to factor in some of the psychosocial factors that parents are experiencing for kids that are going through NAS. So we have families where maybe parents are still in active substance use and kind of struggling with ups and downs of their own. They might be afraid to seek treatment. They might be afraid that if they admit what's going on, that they're going to have a CPS case that would result in the removal of their child. A lot of the families that we work with have financial problems or other barriers that are putting them under chronic stress. And what we really need is exactly what Rhonda said, is that, we need parents to be able to be emotionally available, physically present, and active in their child's treatment.
That is so important. I remember it wasn't that long ago, probably about 5 years ago, I was speaking with one of our senators who, immediately said the best thing we can do for these kids is get them out of that home, as if we're going to save them by taking the child. And that's, really counter to everything that research shows us that is best for the child and families. And I think that, it's important as we talk about awareness that we talk about that piece, that, penalizing the parents, calling CPS, this isn't what is in the best interest of the child physically, or the parents or the mom.
Yes. Earlier, I dropped in the chat a link to a meta-analysis that was addressing the ADHD-like symptoms in children with a history of NAS. I'm going to also now drop in a link for the SAMHSA guidelines for treating pregnant and parenting women with opioid use disorder, which is really the emphasis on the mother-baby dyad and keeping parents supported so that they can be there for their child to attach to.
Yeah. And I think along with that, it's so important. And in my experience, what I found is when I educate and empower a mom, a dad, or that family, like 9 times out of 10, they're going to rise to that occasion and surpass that. And when I explain why we're doing something other than you have to do this, but when I explain why we're doing it and how it's going to help their child in the long run, they follow through. And, I know that there is a lot of concern about stressing a mom out or giving her too much. But I think that in order to keep these families together, we just need to be making sure that we have enough wraparound services for that mom and that baby. And then also, just like we do with any patient care, looking at the priorities. And maybe this month, mom has extra stressors. And so we need to focus on mom. And then next month, baby's not tolerating so much tummy time. So we need to shift our focus. And that's kind of one of the great things about having the opportunity to stay involved with these families. It's kind of constantly changing and shifting to meet the family's needs. And that's really what we're here for, is to help the family succeed.
And, when we talk about the support that women who have a history of substance use disorder let's face it, all new parents need support, period. You know,
Yeah.
That whole thing about taking a village. Our parents are, you know, that do not have a baby with substance exposure or any of that. They're like deer in the headlights, you know. So much of the time they don't know what's normal, what to expect, and they're doubting themselves every moment. And sometimes they get good information, a lot of times it's not so good information. So yeah, I think it's important too that we normalize that, you know, that all parents need more support than what they're getting right now. What we call the fourth trimester, you know, after baby's born. Once baby's born, focus is off mom and it's on baby, but we also need to continue to look after our moms. And as a, you know, obstetrics nurse and working with babies, our job is to try to give folks the best start possible. You know, you're with folks for like 24, 48 hours, you know, on average, but of course with substance exposure, 3-5 days, you know, possibly longer. So we've kind of gotten in our own way for a while by, you know, looking at, and of course we want to protect the babies, of course, but we've now, and I think I've heard everybody say it, we've learned the lesson of, you know, that separation is not going to help that child down the road. Not.
And I will say, like, just having been doing this for 20 years, you know, we've seen when we've only focused on the mom, we've seen when we've only focused on the baby, and neither way has worked well for really anybody. And it's only been very recently where we're really looking at the whole family dynamic and saying, okay, let's focus on this and move forward. And that seems to be doing better. Now, not all children are going to be able to go home, or at least initially, with their parents. And that's okay too, you know, because like Molly said, it's all about the safety of everybody involved, not just the baby, but also the mom, and, you know, making sure she's making good decisions and she knows where she can go for help if she needs help, if she feels stressed out. And, you know, I think we all take for granted that new moms are sleep deprived, but if you're sleep deprived and you're stressed and you don't know where your next meal's coming from, you know what I mean? It's like, it's so much more. And, you know, I'm tired of people saying, oh, well, you're a new mom, you're supposed to be tired. Well, you know, I always tell my families that's an emergency, because nothing is okay and nothing appears normal when you're all sleep deprived. Everything's an emergency, everything's a stressor.
That's a good point. And I don't want to take us too far off the track of where we thought the conversation would go. But, you know, I'm thinking of a provider I knew in the Greenbrier County area years ago who said, you know, you get to know these families and you really care for them. And then the mom delivers and then I never see them again. And I know she needs supports and I know what's available in our county. She said, I almost want to just stand in the front of the Walmart because I know that they're going to come through here sometime so I can check on them and make sure they have everything so that they need. So, you know, one of the problems that we have is this lack of continuity of care and resources that these moms and families have, you know, once they deliver, and, you know, you have that few days of care. And then as they get older, you know, as they age out of birth to 3, as they hit school, I mean, what's available to them, and, you know, lack of kind of continuity of care and services is a real problem.
Well, and I know, Kelly, I shared the slide with you that, you know, this was several years ago, but it was presented at the beginning of COVID on the ICC for West Virginia birth to 3. And in 2017 and 2018, only 10% of the babies that were actually referred to the program with NAS actually were receiving services. Now, when they looked at that, some of it was they didn't get referred, some of it was they had moved, some of it was the family wasn't interested in services, you know, things like that. But we as a state and all other home visitation programs that are being offered, we need to be making sure that at least one of those programs is getting into the home and just like supporting positive parenting with the mom. Of course, as a physical therapist, I want to feel and see the movement quality, but you know, that's not always necessary for every child with NAS. But I think it's really important to stick with those early, you know, and like back to sleep, belly to play, but an hour of tummy time starting at birth that goes up to 90 minutes collectively starting at 3 months. And that baby should crawl for about 4.5 months before they walk. And that's all because we're developing midline motor control and good core strength. And when we don't do that, those are the kiddos that we see who tend to have poor proprioceptive awareness, who might be running into things as they're playing around, might be running into their classmates if they're going to daycare, things like that. So I think that, again, we kind of forget how critical some of that early developmental stages are on setting these kids up for success as they get older.
I'll share one thing that we've done in the greater Huntington area here in Cabell County, and Rhonda is also involved. The Healthy Connections Coalition is a group of over 20 different service providers in the area, ranging from Marshall Health and all of our various divisions that work with families that experience neonatal abstinence syndrome, Lily's Place, Birth to 3, Parents as Teachers. I don't want to offend anyone by trailing off, but we have a lot of folks that work with these families, and we all get to see kind of through our own tiny little window of how that family's doing based on context. So we get together as a coalition at least once monthly to discuss different things. You know, maybe that's legislation, maybe that's funding streams, maybe that's a new service that's available that we've been waiting on. And so we really rely on each other as a community to figure out what we can do to fill in these gaps for our families. One of the things that has come about from that is our family navigation service, which is our version of our drug-free moms and babies program, run through Marshall Health and Cabell Huntington Hospital / Hoops Family Children's Hospital. And we have, I like to call them freelance case managers, because, you know, if they leave their prenatal provider, if they leave their substance use disorder provider, they can still work with our family navigators. So they can go wherever the family goes. And at whatever point in our continuum of care they're identified as either a pregnant woman having a substance use disorder or an infant who's prenatally exposed to substances, we can hang on to that family and help them to navigate through all those different, 25 plus programs that we have in our area, and make sure that they are getting support until they are eligible to receive some services at the public school time frame. Because those first 3 years are extremely important developmentally, and that's the time when kids are not necessarily required to be in school. So we really want to stand next to families and make sure that they're getting everything that they need and that we have.
Yeah. And I think having them understand why it's so critical really goes a long way. And I know, like, I present this a lot, but, we know that we can double a baby's brain size in the first 1 to 2 years of their life through positive bonding. And so that positive bonding with a mom, it's free brain growth, which I'm thrilled about because it gives me more neurons and like places to like work on things. And so, I think, again, it's important to like let them know why it's so critical that, we want you loving on your baby. We want you interacting with your baby. We want you reading to your baby, and just setting them all up with those services so that they understand just how important they are in their baby's life.
Great point. Before we move on to discuss a little bit about what research is needed, what are some other potential long-term effects of neonatal abstinence syndrome? I remember right before this legislative session, Jeremiah Samples with the Department of Health and Human Resources presented to say that it can cost up to $2 million in additional services that a person may need to adulthood. That would be, you know, paid for through the state by taxpayers. And so early intervention is so important. So what kind of long-term effects are we talking about?
Well, I know that babies can have issues like with vision and hearing. A lot of times there's chronic ear infections, so they might need tubes. But you know, so often we think of IQ, and it's not a matter of IQ with most of these children. They're smart, they're resilient, but their executive functioning, they struggle with. So it's, you know, I call it like your filter, and not using your filter appropriately to get out there. And so those are the kids that might be extra impulsive when they get to school, might have a hard time following rules in school. Their volume might be much louder than normal. Sometimes it's quieter. The thing that I'm always concerned about is the sensory processing dysfunction. So they might be scared to move or be a thrill seeker and ready to launch themselves off of anything. And then typically what I often see is that children do not have an intact pain sensation. Most of the time it's a higher pain sensation. So, you know, the kid who launches himself off the monkey bars, fall flats on his face, and then jumps up and is doing it again, that's a red flag, because I don't think that it probably didn't hurt. Their body's just not responding to those pain receptors the same way someone who was not exposed in utero would.
What we see with those executive functioning challenges is that they become more apparent, and the discrepancy between children who have a history of substance exposure prenatally and then those who have not widens the further along kids get in school, when they are required to take on more of those planning, inhibition, like those tasks that teachers really help out with a lot in elementary school. As kids are expected to do more of those things independently, we really see kids that have a history of prenatal substance exposure struggling.
And I was going to say one thing I see too, like especially like if a child doesn't qualify maybe for like during their third year preschool for any kind of services, then they kind of go into what I call a child-driven or child-led world. So if they want to play with this toy, they can play with this toy, or they can bounce to this toy. And then when they transition into the schools, all of a sudden there is a teacher who kind of has classroom rules and wants the children to do things a certain way. And a lot of times these children who have been born substance exposed are like, whoa, I want my child-driven world back. I don't want the adult-directed world. And so I think too, there's a power struggle with, you know, just helping them transition into that. And emotional endurance for all kids can be challenging, but then, you know, these kids a month into school, 6 weeks into school might still be struggling with like remembering what the rules are and remembering all of those things. Whereas a typical nervous system has kind of been like, okay, we've practiced it enough, I'm going to comply. Whereas the child with NAS might still be pushing the boundaries, not to be difficult, but just because they don't have that executive functioning skills intact.
Thanks, Cindy. I was going to say, you know, I have a friend who's a primary care provider in a rural part of the state, and she said, you know, there are some children she sees that really don't have any issues until adolescence. And then you really wonder, you know, what the child's medical history is, but it's not available to them. And then she said, you know, there's this myriad of testing that you want to see done, but the testing isn't available in their area. You have to send them to certain places, and you're not sure where, you know, in the state you can actually send the child for specific testing. And so that's where it gets very complicated for her. So, you know, a child that they think is, you know, may not exhibit any indications of being born drug exposed may at later years. And that's concerning, I'm sure, particularly for the public education system. It wasn't too long ago, I don't know if you saw an op-ed in the Gazette, where an older teacher said, I'm tired of these kids who lack discipline. And there's that thinking that children's adverse behaviors or a lack, of kind of standard behaviors or what they would consider normal behaviors in school is due to, not having discipline at home, when could quite often can be a number of things and not, the need for more discipline is not the answer to the
No, there's need for more structure, but not necessarily discipline. And, we're never going to fit the square peg or the triangle peg or the octagon peg in the round hole. And I mean, the days of there only being one kind of student, to me, as a physical therapist who works with all kinds of different kiddos, is no more. I mean, I just think about, 25 years ago, like what Votech did, you know what I mean? And the hands-on learners all gravitated towards being able to get up in shop class and do all of that stuff. And now we have probably many more learners who need hands-on, who need to move, who need more than just one mode of learning something. And so I think that, unfortunately for the schools, they're still not necessarily talking about NAS and substance exposure in utero to the teachers on how to set up their classroom. I know that like just the visual supports alone, like I tell teachers that all the time, if you can give them the visual schedule, they might be hanging on by a toenail of misbehaving. But if they know by looking at that schedule that they've only got to last 2 more minutes, they might do it. And so there's so much that we can be doing in the schools that is low tech, no tech, that will help those kids who need to move a little bit more succeed.
We talk about with daycares and preschools having an area for time out that's not punishment, but a time to just regroup and then be able to join the others again.
Absolutely. And I know biting tends to be a challenge with daycares. And a lot of times it's not necessarily biting out of malice or frustration. It's biting because they're sensory seeking, or they just need a little more information, like a chewy tube, a Z-Vibe, or something just to kind of wake up their oral motor muscles, but they bite. And so people assume, oh, they're mean or they're doing it out of malice, but you really, again, need to figure out why they're biting and if it truly is a behavior or if it's sensory seeking. And I know we do a lot of talking to daycares in the southern part of the state just about why a child might bite and just strategies on help avoiding that so that nobody's getting kicked out of daycare.
Yeah, I was surprised to hear that. And I'm not sure if this is still the case. The kindergarten was the #1 grade where kids were getting most kicked out of school. But at any rate, I digress. Let's ask this next question, which I think is an important one. What don't we know? Meaning, what kind of research needs to be done to better understand the impact of neonatal abstinence syndrome on generations of children?
I think one of the big concerns that we've had with the quality of research, although in the chat log today, I've posted a couple different meta-analyses, but what we see is that it's really hard to untangle some of the psychosocial stressors that families are experiencing from the direct effects of any substance that the child was exposed to prenatally. It's not impossible. So a really well-designed study, even though it would have to be quasi-experimental because we can't randomly assign people to be prenatally exposed or not, but we really could try to control better for some of the psychosocial variables. And on top of that, even cigarette smoking. So we really, it's difficult when you see a control group of, middle to upper middle class pregnant women who also don't smoke, and we're comparing that to, a clinical population. We're going to find differences, but what is the cause of those differences? I think we sometimes aren't 100% sure.
And I know that I've been saying this for years, or kind of just, it's like, if we see something you know, working in birth to 3, I want to address it and I want to be working on it, because my goal is to always work myself out of a job. And what can start as a sensory challenge or something that's difficult in a toddler can manifest into a much bigger problem and turn into psychological issues if they're unchecked. And so it's like, you know, that's again why it's so critical to understand why we're doing what we're doing. And again, like these kiddos, like Jennifer said, it's like, it's not just drug exposure. You know, we have food insecurities, we have housing and, you know, insufficiencies. There's so many different things going on, that it is hard, but it's like, if we see it, let's work on it. You know what I mean? It's like, oh, well, we just can work on development or what have you. No, if you're treating the whole family, you know, then we want to teach that family how to succeed, or teach them to fish so they won't need us anymore.
So just for panelists, my computer's freezing a bit. So if you see any
Okay.
questions or comments on YouTube, please feel free to share them with the rest of us, as I can't see them. So let's ask what's going on in the state, because I know that I believe, I haven't checked the data, but I still think that we're #1 in the country for children born with neonatal abstinence syndrome. So I know that there have been a lot of good things, like in Huntington, for example, there's been a lot of work to address neonatal abstinence syndrome as a state. So what is it that we're doing right? What's working?
Well, I think we're identifying the children. I think one thing that we talked about when we did our pre-talk was, you know, if we had universal screening, it might take some of the stigma out of it. But then also, I think one frustration that I heard all of us experience is like the mom who might be using marijuana during pregnancy versus a mom who's tested and has been clean throughout her pregnancy on a medical assisted treatment are not always treated the same. And so I think that as a system, we need to do a better job educating our judges, our CPS workers, our pediatricians, so that they understand all of that and they understand the risk factors, because, you know, one isn't, at the end of the day, they're all illegal. And so we need to be assuring that our children are safe. And I think conversations like this ongoing, where people know what's happening across the state, what is going on, because again, I think that it's really easy to get stuck in your silo or get stuck in Huntington or in Morgantown or in Charleston and not realize that, you know, in the southern part of the state, we are still severely lacking in most of the counties. And we just need to continue to expect more or call for more consistency across the whole entire state. Like the family navigator, like if every mom could have that, just imagine how fabulous that would be. And I think about what Jeremiah said with that $2 million price tag. And at this stage of the game, I don't necessarily know how much of that $2 million is going towards positive things for the child. I think it's we're losing a lot of that money doing other things. And so just imagine if we could put $2 million to help a child succeed, to help a family succeed. And that's one thing that I would love to see shift, is just, you know, how we're spending our money and being very thoughtful on, you know, it took us 50 years to get to this place, and it's going to take us 100 years to get out of it. So there is no one quick fix. I've yet to meet 2 families who are exactly the same, and we need to be treating families individually and not cookie cutter them, because we know that doesn't work.
It is difficult, I think, when we live in this area of the field, we see up close and personal what some of the difficulties remain. So it can be hard to answer questions like these, but I do want to kind of highlight some things that I think we do well as a state, you know, in my frame of reference of working with other states. I do think we collaborate relatively well. I don't know if that's part of our culture or just out of necessity, You know, we don't really necessarily have some of the things that states with more urban areas have. So we kind of have to make do and talk to one another and make these systems. We do have expansion of programs like our family navigation program. So that has been supported by Perinatal Partnerships, Drug-Free Moms and Babies program. And we are up to, I believe, 17 sites. Mm-hmm. So there are programs, not exactly the same, because we do get to have, you know, kind of individualized for our area, because the counties, you know, we couldn't be more different from one another. You all know that. But there are 17 programs like that in the state, which just boggles my mind. I think that's amazing. I think of what Lily's Place is doing. It's so innovative. Again, compared to the rest of the country, it's pretty unique. But having that really, you know, family-centered care available, where families are able to visit and stay with their infants during that really critical period in a really homey, comfortable setting. It doesn't feel like you're staying in a hospital when you're visiting your child at Lily's Place. And I think that that's really innovative, something that we do.
You know, I would agree. And I remember, you know, I would say even 5-7 years ago, when we started talking about neonatal abstinence syndrome, you know, and then how we needed to collectively as a state address it. And then Lily's Place came along, and it seemed the conversations with legislature, because they still talked about it. And the talk was, you know, Lily's Place is kind of the gold standard that we would see more of them around the state. So, you know, why don't we have more Lily's Places, right? What happened when Jeremiah was talking about neonatal abstinence syndrome just a few months ago, before session, he gave this really provocative presentation with these really hard stats. And then only one reporter covered it. And then I didn't hear anything about neonatal abstinence syndrome during session. So, you know, we're never going to get to a place where we see more of these Lily's Places around the state until we can find a way to get our legislature and our communities, you know, more like Huntington does, to make it a topic of conversation and more collaboration to get folks involved.
Well, and I think until we make children who are our future a priority, then, you know what I mean, we're always going to be kind of lagging up behind. Because if you look at our numbers, currently like 1 in 5 babies are born with intrauterine substance exposure. So that's 20% of our future population. So that's 20% of the workforce, you know. And then if you factor in individuals who have a disability, individuals who have other issues that take them away from the workforce, it's scary if we're not supporting these kids and expecting them to kind of comply in a system versus, you know, giving them the services, whether it be a 504 or an IEP that they need.
I think, you know, early on, everyone grappled, you know, with, well, what do we do? How do we take care of the babies? And so, you know, I keep hearing a common theme here as far as like consistency. And that is something that we've really worked towards as far as the providers, the hospitals, the hospital staff, the docs that are taking care of all the babies to be on the same page in how they diagnose and that kind of thing. At the same time, we were trying to like put our finger in the dike there, you know, plug the hole, because you know, everyone soon learned, or the folks, you know, working in the area learned, there was little to nothing in the way of treatment for women, much less women with children in the state. Now, it's getting better, but does everyone know about all of the resources? No. Do we need more resources? Yes. You know, all of that, so many areas. But I think, you know, that the more that we can get folks after hospital, you know, on the same page and and try to reduce that stigma. And when I say stigma, I mean, you know, folks who understand substance use disorder, mental health issues and all, that varies so much from folks, and the importance and the impact and all. And, you know, to be able to just keep doing that and educating folks so that when we turn around, you know, I love Cindy's thing about standing out in front of the Walmart, you know, to see people. Yeah. It's a beauty of living in a small town, you know, too. But the more support they can get from their community, the more that folks understand, and it's not a moral shortcoming, you know, and we're not trying to like punish people. We're trying to get folks help so the kids will benefit.
And I think we're at that critical place. Like, Molly, I think you're 100% right. I think we're doing a good job up until like discharge. You know what I mean? And now it's time to kind of like up our game with pediatricians. And I know that I have been doing a lot of trainings with early Head Start, and just providers, because now we know these kids are going home and these kids might be experiencing some challenges. And when we did a family questionnaire with To the Moon and Back 2 months ago, one of the comments really hit home to me, because she said, I feel like they're experimenting and figuring out what's going to work with my daughter. And she's like, and I want the very best for my daughter too. And I think she's right. You know what I mean? And so we just all need to be more thoughtful on, these are not test cases, these are human beings and children and families, and they deserve the absolute best from us, just like all of our other patients do. And, you know, and again, I think it's just a matter of talking about it, and we haven't talked about it, you know, for so long.
Yeah, I think when substance use, when it's cast in like a moral framework, it can be really divisive, and it makes it difficult for us to come to a common ground. But really focusing on this, you know, generation of children coming up, I think also having a trauma-informed approach is very important, because some of the kids that are being born now, those young parents who are, you know, in their late teens, early 20s, are the children of the beginning of the opioid epidemic. So there's a lot of intergenerational trauma, and you know, people not necessarily having the opportunity to learn things that a lot of people take for granted in terms of emotional regulation, bonding, parenting, and you know, whether we disagree with what started the cycle or not, we are raising our community members. You know, I want to be able to, you know, go to the doctor when I'm elderly and have someone in my community that I'm able to see, because we have worked to support everyone in our community to make it stronger.
And I think what goes right along with that is looking at our prevention piece and how we're going to do prevention, because just saying no is not going to work. We know that if you were born substance exposed, you have a greater risk of struggling with substance use disorder as you get older. And we also know that if we can shift the trajectory even 1 or 2 years to experimenting at 17 versus at 12 or 13, what that means. And so Fayette County is involved in the ICE collaborative with Dr. Christensen from WVU. And I know that's just one prevention program, but when I see what it does for families, and having like our Project Adventure and our adventure days where the whole family can come out and recreate, like, it's just so amazing to see communities coming together and just watching that bonding that's happening that we don't often get to see like in real time.
That's a great point. We have 8 minutes left, and there are 2 really important questions I want to make sure I get in front of you all. Imagine if we created a strategic plan to address neonatal abstinence syndrome in West Virginia, including all systems like healthcare, public ed, child welfare, foster care, and the court system. What would you think would be the first step that you would recommend for the state to address?
Assuring that that information follows the child all the way up through adulthood, not to stigmatize, but to give them accurate information. So if they are struggling at different phases as they grow older, that you can look back and not be dependent on somebody who might feel vulnerable sharing that information, sharing it.
A lot of things pop in my head when you say that, Cindy. I remember the conversations years ago with the Perinatal Partnership about, it was kind of a back and forth. Do you, how much data do you share because of stigma? And then the problem with, siloed systems to begin with. So the public ed system doesn't have access to the healthcare system. And so how much data should be shared, and, how much stigma will follow the child depending on how much of that data is shared.
Yeah.
Oh,
go ahead, Molly.
I think it's important to bring all these groups together, in some way, because we're looking at such a huge problem with so many different facets, and we want all these groups, to be on that same page. So I think to be able to come together on a regular basis, and we've done that with tobacco. For example, with tobacco use in pregnancy, we're not where we need to be yet, but we've brought together key folks in the state, the Coalition for Tobacco-Free West Virginia, bringing together all these groups of people from all these different walks. And, part of that state government, the other part is, healthcare folks. And then you've got the foster care system, so many areas, so that people don't stick around in those silos and try to reinvent the wheel. Just to share information, and that's the only way I think it can get better, is the more across all those areas, and that for folks can come together. Problem is, it's a always changing, interchangeable puzzle going on, because people come and go from different organizations. But to keep that in mind, to keep that conversation going between all these different areas.
I think it's important to involve families that we're talking about. And like we are developing, Jen is heading this up, a family, what's it called? Family Advisory Board. Yes. And because sometimes we have what we think are great ideas, but then when it gets down and the rubber meets the road, it's like, oh, maybe that's not going to work. So I feel like including them in all these discussions would be beneficial.
I couldn't agree with you more, Rhonda, because it's almost funny when you get all of these systems together and they talk about their kids and their systems, and you think these are the same kids and families that are going through all these systems, and they don't get how their systems can work together, but the families do, because the families have to live it. And so, yeah, that's a really important point, I think.
And they know how much a nightmare it can be sometimes to interchange and work with those systems, and how stressful it can be.
And I think particularly revisiting barriers to treatment in light of what some of our families have to say. So, we know, all of us on this panel know that early intervention is critical, particularly during the prenatal period. If someone can access prenatal care, if someone is interested in treatment and can get stabilized in a treatment program, that's going to improve outcomes for that child. And yet we do have a lot of policies, and maybe that's not the intent of the policy, but it's how it's actually enacted in some of different areas around the state. And as Molly said, inconsistency.
Yeah.
So if you have a case in one county, it can be handled completely differently than if you have a CPS case in the neighboring county. And some of the things that are barriers to treatment, we really need to get real about what's best for our communities and revisit how we handle those things.
Yeah. And you're 100% right about just who and how. If it's the same law, we should all be interpreting this law the same way. But two judges, two guardian ad litems, two prosecuting attorneys, everybody sees it different, and there are different rules in different counties, and that's not the way it should be. I don't believe that's what CAPTA was ever designed for, but again, until we have consistency with some of the leadership, like in CPS, and we can maintain staff, I mean, I could not do their job. I mean, I'm, you know what I mean? I have a hard enough time maintaining my caseload, let alone tripling or quadrupling that and expecting them to be able to have working understanding of all of that. So I think we just also need to keep expecting more, and keep asking for more, because again, we're not talking about numbers, we're not talking about objects, we're talking about children and families, and they deserve our attention.
I agree. And I think until, maybe Rhonda and Jen will have an easy time recruiting family members for this advisory group. It's been my experience that, I'll have folks who are willing to share their experiences with me personally, but the notion of kind of putting it out there is really very frightening to them, especially with the stigma that we deal with. So until we can really get people who are brave and confident enough to share those experiences, we really have to be the people with our policymakers to say this is what has to be done. Because it's been my experience that legislators want to do something, but they have no idea what it is. So it's really kind of our job to present it as, here is what needs to happen, and then really advocate on that level. Okay, so the one more question, because we are out of time. Is there any last thought or takeaway that you all have that we haven't discussed yet? Covered a lot of ground.
It's like, I just say never, you know what I mean? Like, we talk a lot about what these families can't do, but I think we need to be focusing on what these families can do, and the sky's the limit. And I know we've kind of said this before, if we gave these families half of the opportunities that some of our foster families have, like, they might not ever have needed CPS to get involved. So I just really want to focus on the positives and what we can do, and not what people say we can't do.
I agree. It's like Senator Stallings often says, move upstream. So catch these kids when they're babies, and give them and the families what they need to succeed. And I think we would see much different outcomes. So that is the end. I am so appreciative of all your time, Cindy, Rhonda, Molly, and Jen. This conversation hopefully won't end here. Folks are welcome to share any questions or thoughts in the comments below. We'll keep an eye on it over the next few days. And if anyone else has any questions, they can send them to Think Kids, and we'll share it with the panel. Again, thanks for everyone's time, and I hope you have a great day. Bye-bye.